Hello, partnering for vaccine equity learning community members and others working on vaccine equity. And welcome to this afternoon's learning event. My name is Kristen Brown, and on behalf of our team at the Urban Institute, thanks for joining us. Today's event is part of our Social Determinants of Health series, which will occur on the third Wednesday of every month. And today, we will hear about the role of transportation on healthcare use during the COVID-19 pandemic and how this relates to the increasing popularity of telehealth. Before we go further, I'll do our typical quick review of how this session will work. You've all been muted upon entry to the session. There are a lot of us, so staying on mute unless you are speaking is key to keeping the discussion going without accidental interruption. You do have the opportunity to speak your question rather than type into Q&A. It's your choice. If you want to speak your question, use the raised hand feature and we'll unmute you. If you want to type in your question, use the Q&A tab to do this, and you can ask a question during the session. The chat room feature is also open today, and we encourage you to chat amongst yourselves as you'd like, but please use good chat room etiquette. By this, I mean do not post questions for the speaker in the chat because we might not see them there. And although this probably goes without saying, please be civil to one another and to our speaker while chatting. We are offering live interpretation from English to Spanish during our events. If you'd like to listen to the Spanish language channel, simply click on the globe icon in the Zoom taskbar at the bottom of your screen. Finally, as with all of our learning events, we'll post the slides and a recording of this event on our community website and circulate them through the digest that go out through the CDC-managed Adult Vax Program listserv, which all program members should be a part of. If you have technical difficulties at any point during the session, please send an email to our community manager inbox at vaxequitylearning@urban.org. We'll be watching the inbox and we'll try to help you as quickly as we can. And now it is my pleasure to introduce our featured speaker. Dr. Laura Smith is a research associate in the Health Policy Center at the Urban Institute. She specializes in quantitative research on the impacts of health policy programs and is an expert in using large novel data sets, such as those from electronic health record systems in her research. Her current areas of study include patterns of telehealth during and following the COVID-19 pandemic, racial health equity among Medicaid-enrolled children, and the relationship between transportation and access to healthcare. Laura holds a PhD in Health Services Research from the University of Minnesota School of Public Health and a BA in Mathematics from St. Olaf College. Thank you, Dr. Smith, for taking the time to speak with us today, and I'll hand it off to you now.
All right, thank you so much, Kristen and Sophia and Alicia and everyone else for inviting me to present today. As Kristen just said, my name is Laura. I use she, her pronouns, and I'm a research associate in the Health Policy Center at the Urban Institute in Washington, D.C. And I was going to share a little bit more about my background, but Kristen kind of covered it. So I'm trained in healthcare economics and policy, and I do research that uses data to analyze patterns in healthcare, and especially focusing on access to care and equity and access to care and how this is influenced by various policy-related factors. So today, my presentation is all about one of the main focuses of my research, which is transportation as a social determinant of health, and in particular, transportation and how it helps us reach our doctors, both before and then also during the COVID-19 pandemic. And I'm going to talk about 3 different studies that I've worked on and what we can kind of learn from each of them related to this topic. So first, to set the stage, I know that this group talks a lot about social determinants of health, so hopefully this isn't too repetitive, but I just wanted to start by sharing the CDC's definition for social determinants of health. So the CDC defines them as, quote, non-medical factors that influence health outcomes. So this includes the conditions in which, actually, this is still part of their definition. It includes the conditions in which people are born, where they grow up, where they work, where they live, and ultimately where they age. It includes the wider set of forces and systems shaping the conditions of daily life, including economic policies and systems, development agendas, social norms, social policies, racism, climate change, and political systems. So this is obviously a whole lot of things. Some more specific examples of social determinants of health include housing, food insecurity, immigration status, And then, of course, transportation, which is what I'm talking about today. Can go to the next slide. So in what ways is transportation a social determinant of health? Based on the definition I just gave, this question really is, in what ways does transportation influence our health outcomes? And I think there are actually lots of ways in which transportation can influence our health outcomes in both good and bad ways. So here I list 5 of those, but I'm sure there are others as well. So first, access to transportation can help us get to work or to school, or help us reach grocery stores with healthy food options, all of which can influence our health. Second, living in walkable or bike-friendly neighborhoods can improve our health by making it easier to exercise or by just making exercise part of our daily routine for getting to work or school. Third, traffic accidents, unfortunately, are a leading cause of death. So safe transportation is really key for our health and safety. Fourth, emissions from vehicles and other forms of transportation contribute to poor air quality, which then directly affects our health. And then finally, transportation helps us access the doctor when we need them. So this last example is obviously the focus of a lot of my research and my presentation today. So this is what I'm going to be really talking about on the next slides, but I did want to be sure to provide the broader context of transportation as a social determinant of health and point out that there are actually many different ways in which it can be considered one. Next slide, please. So the research that I'll talk about today has to do with transportation and accessing healthcare. And in particular, I have explored 3 main questions on this topic. So first, how often are people unable to get to the doctor because of transportation problems or transportation barriers? And importantly, are there inequities in who is more likely to have transportation barriers or have issues accessing the doctor because of transportation? Second, how important is public transportation? So this could include things like buses, subways, light rail lines, etc. How important is public transportation in helping people get to the doctor? And related to that, as one possible solution to help people get to the doctor, does expanding public transportation systems help people get to the doctor more easily? And then third, as another option for having to actually, or a substitute for having to actually use transportation, can phone or video visits, which are sometimes called telehealth or telemedicine, can that be a tool to help people, reach their doctors and get the healthcare they need without having to use transportation at all? So these are the 3 questions that I'm going to dive into now. Next slide, please. Okay, so first, just to set the stage, I want to talk a little bit about the types of transportation that we have here in the US. So first, privately owned vehicles or cars are by far the most common type of transportation in the US. Our research, our survey finds that over 90% of US adults own or have access to a private vehicle. However, it's really important to know that this is not equally true for all groups of people by any stretch. In particular, in our survey, we found that Black, Hispanic, and Latinx adults, adults with low incomes, and adults with disabilities are all much less likely to own or have access to private vehicles. So it's important to keep this in mind when we're thinking about a healthcare system that tends to really require or assume that people have a vehicle to get around. In addition to cars, though, public transit systems, which again might include buses or subways, these are available in most major US cities. However, the public transit systems that we have may not be reachable or affordable for everybody equitably. They're generally not available at all in more rural areas. And just because public transit systems exist does not mean that everybody's able to access them or that everybody lives near them, or that the lines or the stops that are near people's homes actually take them to where they need to go. And also, while public transit is generally and usually less expensive than owning a car, it can still be costly, both in terms of money, but also people's time. Next slide, please. So, in terms of access to public transit, we have looked at this a bit in our research, and we focus especially on the 10% of people who in the US who do not have their own private vehicles. So, among these people who do not have vehicles, about 32%, or almost one third, say they do not have good access to public transportation where they live. And another 32%, or about one third, say that they are not able to get around easily without driving. So, both of these things, these are even more commonly reported for adults with low incomes and adults with disabilities. We also did something in our study where we compared people's answers to these questions about their access to public transit and their ability to get around to some data that we got from Google Maps that actually showed us the frequency and distance of public transit stops from their homes. And interestingly, what we found was that there was actually not a very strong correlation between people's reported experiences with accessing public transit and with these quote unquote objective measures of public transit availability, which really goes to show that just because public transit technically exists does not mean that it's easy for people to use. And this really highlights that when possible, it's important to ask people about their lived experiences to understand how transportation works in their lives. Next slide. So the next major question in our research was to try to see how many people actually have to miss doctor's appointments because of problems with transportation. And again, we surveyed over 9,000 adults living across the US, and we found that 5% overall had to miss a doctor's appointment because of transportation barriers. This number was a lot higher when we focus on people who do not have a car. For people who do not have a car, 13% had to miss a doctor's visit recently because of transportation barriers. And these transportation barriers were even more common for Black adults, for Hispanic and Latinx adults, for adults with lower incomes, and for adults with disabilities, showing, again, there is inequity in who is more at risk for missing doctor's appointments because of transportation. Next slide. Okay, so this is kind of the key finding from this study and like the most important one in my mind. So I've just devoted an entire slide to it. But essentially, we found that when we focused on people who do not have a car and people who reported that they did not have good access to public transportation, 1 in 5, or 20% of them, missed doctor's visits in the last year because of difficulty finding transportation. So to me, this really puts the seriousness of this issue into perspective and shows that policymakers and doctors and healthcare providers really need to be thinking about this barrier that many patients face when we're thinking about how to improve equity in the healthcare system. For example, it means that if we want to improve health and health equity, we need to think outside the box about other parts of our environment that need to change to help people reach the doctor. So for transportation, one solution could be to invest more in our public transit systems to make them more widespread, more usable, more affordable. And this concept of investing or expanding in public transit systems is sort of exactly what the next study that we did is all about. So we can go to the next slide. Thank you. So in this next study, we set out to answer the question of what happens when public transit systems expand in terms of people's ability to reach their doctors. And to do this, we looked at how often people had to miss a doctor's appointment that they had previously scheduled. And we looked at this before and after a new light rail line that ran right by many doctor's offices opened. So, in order to be able to say something about these patterns on a large scale, we analyzed data on over 3 million people, and we had data from across 4 years. So 2 of these years were before the new light rail line opened, and 2 of them were after the new light rail line opened. So we were basically able to see how often people missed their scheduled appointments before and then after the new light rail line opened to see if the number of missed visits dropped because of the light rail. We also were able to compare how often missed visits change for people who are living near the new light rail compared to people not living near the new light rail, with the idea being that we would expect people living near the new light rail to be even more impacted by this than people not living near the new light rail. Next slide, please. Oh yeah, so just before I get into the details of the study, I just wanted to share a little bit more about the context for this study. So it was in June of 2014 in the Twin Cities of Minneapolis and St. Paul in Minnesota, which is where I happen to be doing my graduate studies at the time. And the Metro Green Line light rail opened. And that's pictured here. And the Green Line light rail connects downtown Minneapolis to downtown St. Paul. It also travels through several of the lowest income neighborhoods in the Twin Cities and directly past several large doctor's offices and healthcare facilities. So the Green Line, when it opened, it more than doubled existing light rail ridership in the city and substantially increased public transit access overall. So it really was a significant improvement in public transit for this community. Next slide, please. So we were able to get access to data from the major health system that told us how often people scheduled and then missed appointments. And after we analyzed all this data, what we found was that significantly fewer people missed their scheduled doctor's visits after the new light rail line opened. And so significantly fewer people missed their appointments after the light rail line opened. And even more interestingly, these effects were greatest for people with Medicaid health insurance coverage, many of whom are people with lower incomes. So for this group of people, missed doctor's visits dropped by 8.6% relative to what we would have expected had the light rail line not opened. Next slide, please. So in terms of what we can take away from this study, including how we interpret the results and what the limitations are that we need to keep in mind. So we did observe a big drop in missed visits when public transit expanded, which really is sort of compelling evidence that public transit can help people reach the doctor. However, we also keep in mind that many people are still missing visits, even with the new expanded light rail system. So the problem has not been like entirely fixed. And I also want to note that some public health insurance plans, like Medicaid or other state plans, offer benefits to cover transportation to and from doctors' offices, including covering public transit fares. But the rules for these policies can be complicated and they vary a lot in different states and different programs. And it's sort of known that these benefits are not used very often or they're not used consistently across different states. So expanding these types of benefits may be part of a solution, but there does need to definitely be a more holistic approach taken as well. And then an important limitation of this study is that we were not able to talk to people about their experiences to learn what barriers they faced related to transportation or to hear what their experience was like using the light rail or what could still be improved to help them access the doctor. And then finally, just always good to keep in mind that this study took place in one specific area, which was Minneapolis and St. Paul in Minnesota. And therefore, the patterns that we found there might not necessarily be the same in other parts of the country. And interventions should always be tailored to the needs of specific communities as much as possible. Next slide, please. Okay, so by now I've hopefully convinced you that transportation is an important social determinant of health and that improving public transportation can really help more people reach their doctor. So now the next big question I want to talk about is how did the role of transportation as a social determinant of health change during the COVID-19 pandemic? And here, once again, I think there are lots of ways to answer this question and lots of ways that we could come up with that transportation and its relationship with health changed during the pandemic. But here again, I'll brainstorm a few of them to sort of motivate this last part of my talk. So first, financial hardships, job loss, the recession associated with the pandemic made car or vehicle ownership less feasible for many families and therefore made it more difficult for them to reach the doctor. Second, the availability of public transit was actually reduced during the early times of the pandemic. For example, some buses and trains reduced their schedules, offered less options, or closed altogether. Third, public transit was seen or was a risky place for contracting the virus, which may have discouraged people from using it, and especially people who were at high risk for severe cases of COVID-19. And then finally, telehealth, which is using phone or video in place of seeing a doctor in person, grew in popularity as a way to see your doctor without having to leave your home. And I bolded this last one here because telehealth has been another major focus of my research in recent years. And so I wanted to share a little bit more on this topic and especially how telehealth can help or hurt inequities in health related to transportation. Next slide, please. So first, I'll just back up for a second to set the stage a little bit in terms of what telehealth is, what it can do for us, and also what it cannot do for us as a tool. So the definition of telehealth generally is any use of technology or electronic communication to receive healthcare. And this is actually a pretty broad definition, but oftentimes telehealth involves a phone call or video chat between a patient and their doctor. And this is the type of telehealth that my research is mostly focused on, the type that is actually sort of meant to replace the need for an in-person doctor's visit. So in this form of telehealth, doctors can diagnose an illness or an injury. They can recommend, that patients have certain follow-up care or see a specialist. They can even prescribe medication over the phone or video using telehealth, which can obviously be really great for patients. But there are also many things that cannot be done by your doctor using telehealth. Obviously, anything that involves physically touching or seeing a patient or doing a procedure. So things like vaccines or screenings for cancer, exams or labs, these cannot be done using telehealth. And so it's just important to keep in mind that telehealth could never entirely replace the need for us all to see the doctor in real life. Next slide, please. So telehealth has really gotten a lot of attention in the last few years as its popularity has shot up during the pandemic, but it's actually existed as a way to get healthcare and talk to doctors for many years. Before the pandemic, though, only about 1% of people used telehealth. And many of these people lived in rural areas where there were not many doctors nearby. And also, a lot of, or most of the telehealth that happened prior to the pandemic was for mental health care. So typically between patients and a counselor or therapist. There were, part of the reason for this was that there were many laws and regulations in place that made telehealth visits a less popular option for in-person visits for both patients and doctors. So for example, they were often more expensive for patients, and many doctors were not allowed to treat patients using telehealth unless they met sort of a bunch of different regulatory requirements. Slide. Thank you. So then, just like many other things, there were a lot of big changes related to telehealth that happened during the COVID-19 pandemic. So when the pandemic started, a lot of those laws and regulations that were in place to make telehealth less popular were temporarily waived or changed, which made it a lot easier for both patients and doctors to use it. So, for example, health insurance plans were required to start covering telehealth visits for their patients, so that it did not cost patients anything out of pocket to use telehealth. And on the flip side, doctors were also reimbursed or paid to provide telehealth visits at the same rates that they would be paid to provide in-person office visits. Um, there were also various rules about providers not being able to see patients who lived in different states with telehealth and things like that that were just completely relaxed during the pandemic. And these changes that were made were obviously intended to help people be able to stay home, to help avoid spread of the virus that could occur at doctors' offices. And a lot of doctors' offices even closed entirely, especially for any type of healthcare that was not considered an emergency. But then what happened was that several weeks or at least several months into the pandemic, doctors' offices began reopening. People were allowed to schedule their routine healthcare again, and many patients did begin returning to the office for in-person healthcare. But even when this started happening, telehealth continued to be incredibly popular, and these laws and regulations stayed in place for the duration of the public health emergency. So telehealth did not go away. It did not go back to 1% of people using it, as it had been prior to the pandemic. Next slide. So in our study, we again surveyed over 9,000 adults to learn all about their experiences with telehealth during the first year of the pandemic. And here's kind of what we learned from this survey data. So, first, we found that 38% of adults had at least one telehealth visit, whether that was a phone call or video visit, during the first year of the pandemic. So, basically between March 2020 and March 2021. And most of these telehealth visits were for general or routine healthcare issues, although mental health concerns like anxiety and depression were also very popular reasons that people asked or had telehealth visits. And many of the people who used telehealth visits also said that they found telehealth visits to be convenient and easy to schedule, that they did not cost them anything or didn't cost very much. And in general, people reported that they really had high satisfaction with their telehealth visits, which is obviously great. Um, However, the big issue is that there were major disparities in who was actually able to use telehealth. And the 38% of people who had a visit was not consistent across different groups. For example, telehealth visits were much less common for adults with low incomes compared to adults with higher incomes, less common for adults who did not have health insurance compared to adults who had health insurance, and less common for adults living in rural areas compared to adults living in urban areas. So it's just important to remember when we think about telehealth as a solution to, transportation barriers, for example, that there are inequities in this. And many of the people who are likely to face transportation barriers are also likely to face barriers in using telehealth. So just we always need to be thinking about how we can make sure that telehealth is equitably accessible for people. So next slide, please. Okay, so what does telehealth have to do with transportation? So just putting all these thoughts together, I want to talk a little bit about the intersection of telehealth and transportation and health equity. So, a great thing about telehealth is that it does not require you to leave your home. And therefore, by definition, transportation is not a barrier to telehealth. And so, it can be a great option for people who do not have access or who have limited access to transportation. On the other hand, though, telehealth cannot handle all types of healthcare needs. For example, we can't get vaccines through telehealth, or we can't be screened for cancer through telehealth. So we need to make sure that people are also able to get the in-person care that they do need, and that they have the transportation that they need to get to this in-person care, in addition to possibly using telehealth for some other types of healthcare needs. And then also, to use telehealth, people need to have access to a phone or ideally access to the internet. And this is not equally available to everybody. There are many people who do not have broadband internet connection, and this can lead to inequities in access to telehealth. And then finally, not all types of health insurance coverage will pay for telehealth, which could mean that not everyone is able to afford it. And for people who do not have health insurance coverage, telehealth could just be prohibitively expensive. So, this is another example of how access to telehealth is not the same for everyone, and is not a perfect solution to transportation barriers, but rather maybe part of a solution. Next slide, please. Okay, so I'm just about through my slides here, but I just wanted to conclude by going over the key takeaways from the presentation and what I hope everyone has taken away from this. So first is that transportation is an important social determinant of health because it is a non-medical factor that influences health outcomes in many different ways. Second, many people have to miss healthcare visits because they experience barriers to transportation, or they don't have a way to get there. And this is disproportionately affecting people with low incomes and people with disabilities. However, my research shows that expanding public transit systems can actually make a difference and help more people get to the doctor. And especially that can be the case for people with lower incomes. Fourth, telehealth or healthcare provided over the phone or video instead of requiring in-person doctor's visits can improve access to healthcare by helping people avoid the need for transportation at all. However, and finally, telehealth is not equitably available for everyone and cannot cover all healthcare needs. So it's just part of the solution. Other options to help could and should include expanding public transit systems, providing vouchers for transportation to remove cost barriers, connecting patients with healthcare that is located conveniently or near their homes whenever possible, and also providing more flexible hours and appointment scheduling options to help people reach their doctors at times that can work well for them. Next slide, please. That's it. I just want to again thank Kristen and everyone else for inviting me today. Thank you to all of you for taking the time out of your days to attend. I hope that everyone learned something or at least found this to be interesting. And I'd be glad to share more or chat anytime. I included a link to my webpage here, which will have all links to all the studies that I talked about, and also my email. Thank you all so much.
Laura, thank you so much for a great presentation. If anyone has questions, feel free to put it in the Q&A box. I can monitor the Q&A box. But I'm going to ask my question first. So is there any difference between receiving telehealth versus going in person? Like, are people seeing differences in like the quality of care between that?
Yeah, that's a great question. And I think that there have been more and more studies trying to answer that question now that we have kind of a couple years more data on telehealth and outcomes associated with it. What I've seen so far is that people are generally able to get relatively high quality care for telehealth for mental health care. So it's been a great tool for providing high quality therapy or counseling or anxiety and depression treatment. And there's actually some evidence of people's depression and anxiety scores, going down from telehealth in a similar way to how they might for in-person care. But I think for more of like a physical health problem, I think there is some concern that telehealth is not going to be a great substitute because I mean it's sort of obvious, right? Like the doctor isn't actually seeing you. And so it's hard to provide that same level of quality care in telehealth.
And before I ask my next question, we're going to put up the satisfaction poll in the meantime as I ask my next question. So I saw that you said that people in rural areas were less likely to use telehealth. Did that surprise you, or was there reasons for that? I would have thought that with the distance, they would have been more likely. But was that
Yeah,
surprising to you as well?
yeah, it was. And so this is what was interesting was that before the pandemic, it was more common for people in rural areas, and that was partially because of actually laws in Medicare and probably regular private health insurance that like providers were only allowed to provide it to people to provide telehealth to people in rural areas. But then during the pandemic, yeah, it was unexpected to see higher rates of telehealth use for people living in urban areas, and I think part of what explains that is that telehealth was also tended to be more common for younger people, other sort of groups that tended to live in urban areas. Um, and so, but it is sort of counterintuitive and also problematic because we like obviously people living in rural areas are going to have fewer options for where they can go to the doctor, and so I think we would hope to see a more uptake of telehealth in among rural populations.
Yeah. I'm gonna throw out another question because I will going to do it. Um, so I also saw that you said that some insurance companies or some people are covering transportation as as covered so people can get to their doctors. Are you seeing any variation of like by who's actually covering and who's not covering and maybe what the implications of that may be?
Yeah, that's a great question. So it this is like a big gap I think in the research, and I would love to do a more concrete project on this. But so Medicaid has a benefit called non-emergency medical transportation, which is designed to help reimburse people for the expense of getting to and from the doctor. Um, there is so little knowledge out there in terms of how well it's actually working for people and how often it's actually being used. And it looks so different in different states and different Medicaid programs that it's really hard to get a grip on it. And I would bet that it's working fantastic in some places and for some people, but that in other places it's probably completely dysfunctional and not serving the purpose that it's supposed to. There's not much data out there on how often it's actually being used. And in terms of outside of Medicaid, private health insurance, commercial health insurance, I think it's again, it's going to vary a lot. I don't think it's a very common benefit. Maybe some Medicare Advantage plans offer it. I'm not super familiar, but yeah, the variability in that is is a problem.
Right, we have a question from the chat. It says, is there data on whether or not the shift to more telehealth has any significant impact on the frequency of people seeking healthcare services?
Interesting. So basically, has telehealth made it so that more people are able to a more frequency? Okay. Oh, that's interesting. You know, off the top of my head, I'm not sure if we've have much data confirming that people are having more contact overall or having more visits overall with the healthcare system because of telehealth. I would imagine the answer is yes, just based on how many people it seems have used telehealth at all. Um, but yeah, I think like my intuition would be that more people are going to be seeing the doctor more often if you continue to have telehealth be an easy option. I hope that answers the questions. Let me know if not.
We'll go to the next question in the chat. It says, have you done any research specifically in places with little to no public transport? Not rural, but thinking like Wyoming.
Mm, you know, I so the obviously the public transit study that I talked about today was mostly focused on or was only focused on the Minneapolis-St. Paul metro area. The survey data that we have collected is always from a nationally representative survey. So we are including people who live in all parts of the country in that, but I have not done any research that focuses specifically on areas with little to no public transit. And that's obviously going to be a really different set of issues to think about.
If there are no more questions. Or if you still have questions, put them in the chat. I'll just tell you about the upcoming PAVE events in the meantime. Tomorrow we have our joint communities of practice meeting. It's actually an open house, so all are invited. We're going to talk about the Bridge Access Program and what that may mean for all of the work that we're doing in regards to vaccine equity. So make sure that you put that on your calendar. Next week, we have the What to Expect at the 2023 APHA meeting, which will be in November. So if you're attending that meeting or just interested in what to expect at such a meeting, please put that on your calendar for Monday. And then also next week, we have Storytelling in the Palm of Your Hand, which is going to be a two-part smartphone training series. So I just wanted to make you aware of that as well. We do have an additional question in the chat. Who wants to know what's your next step for your research?
Hang on, I was muted. That's a great question. So I would, as Kristen sort of mentioned, I would love to do a study that is more systematically reviewing how different health insurance programs and especially Medicaid handle and offer transportation benefits. That is something I've been wanting to do for a long time. And I think that could involve both sort of a state by state investigation or even survey into how Medicaid programs work with transportation, but then also maybe some data analysis of how often claims are processed for transportation. So that is sort of the pet project that I would love to do. But I'm also really would love to hear ideas or suggestions that people have. So please feel free to email me if you have any great ideas.
Well, Dr. Smith, thank you so much for sharing your research with us today. I'm sure that we can all use this as we're planning our vaccine equity activities. And everyone enjoy the rest of your day.
Thank you so much.